Great. I think we'll make a start. So good afternoon, everyone, and thank you for joining the Community Catalyst webinar today. My name is Professor Lucy Griffiths. I'm the co-lead of our ESRC-funded Catalyst project, which aims to promote the use of linked administrative data and to showcase great examples of ongoing projects across the UK. So today we've got two presentations highlighting how connected data can be used to explore and to answer current questions in children's health, social care and education. So I'm very grateful that we've got three speakers today. So the first presentation will be given by Mark Mon-Williams, and Mark's a professor at the Bradford Institute of Health Research. And his talk today will focus on the use of linked data to address the SEND crisis. And within this, we'll also have the opportunity, of course, to hear about the fantastic work going on in Bradford. And then our second presentation will be delivered by Professor Dougal Hargreaves and George Melrose, both from Imperial College London. And they are going to showcase some work ongoing related to children and young people's mental health. So if you have any questions or comments, please do add them to the Q&A function, and my colleague Grace, who's on the call, we'll pick them up and pass them to the presenters, and we'll have a bit of a discussion after both presentations. So over to you, Mark, when you're ready, please. Thank you.
Oh, that's wonderful. Thanks so much, Lucy, and thanks so much to the team for organising this event. We're passionate about the use of routine data to improve outcomes for children and young people, and it's our belief that we desperately need to improve outcomes for young people across the UK. So thank you so much for inviting us just to share some of the insights that I think we sort of generated within Bradford. And that's because within Bradford, we're very privileged to have a really rich set of data that describes the lives of our children and young people. This first came about through Born in Bradford, which is the large longitudinal birth cohort study, where we not only tested the sort of our children to oblivion in terms of their genetic composition and in terms of all the various factors that influence their outcomes in life, but we also asked permission to link the administrative data sets that describe the children and families' lives. And arguably, this was one of the most powerful aspects of the Born in Bradford project. And what I think that allows us to do is get a much better holistic understanding of the various factors that play out in a child or young person's life and how they ultimately influence the long-term physical, mental health and well-being of that individual. And that ability to play things across the lifespan, I think, is absolutely critical. So typically we tend to see things in a snapshot, where the reality is, of course, that we're dealing with dynamical systems. Our structures are dynamical, our children and young people are dynamical. They change over time. So understanding how those changes occur over time and how early factors can play out over a much longer horizon, I believe is critically important. So through Born in Bradford, we really set out to start breaking down the silos that currently exist between our different organisations and the information that resides on all of their individual servers. And that led us to create a Connected Bradford data set, where instead of each organisation having their own particular view of an individual child or family, we connected the dots. So we have a database that links health and education and social care and criminal justice system and information about the built environment, any other data sets we can get our hands on to really understand what are the various factors that ultimately determine a child or young person's outcomes. And that then suddenly gives us powerful tools to really start understanding the SEND sort of crisis, not as just this unitary phenomenon, but rather as something that reflects a number of structural issues playing out across our different organisations, our different systems and structures. So the Connected Bradford data set, I believe, is an incredibly powerful tool, and I would love to see every nook and cranny throughout the UK having a similar resource. Of course, Wales have got the sort of SAIL database, which similarly allows us to get these holistic viewpoints over time. And I do believe that we really need to start looking at how every area can make advantage of such connected data sets. So if I just think about the type of insights that we glean from Born in Bradford, from Connected Bradford. And if I just sort of think about an archetype that I'm going to describe as Tracy. So Tracy represents thousands of children that we see in our database. And Tracy has a number of different life events. And our connected data allows us to start just exploring the relationship between those different events rather than seeing them as just single snapshots in time. So when we think about Tracy, she has a copy number variant, happens to be 22q deletion. She was born prematurely with a congenital anomaly. Her mother's living in poverty. That means she's lacked rich childhood experiences. At 2 years of age, it was clear she had autistic symptoms on the ASQ. We know there's a bunch of 999 calls that are associated with the home that she lives in. She turns up at school, not school ready. She has poor motor skills observed within the classroom, poor handwriting, bumps into the sort of desks, finds it difficult to join in games out in the playground. Age 10, she starts getting identified with educational needs, gets put on an autism assessment list at 10 years of age. She doesn't really feel like she belongs at school, starts becoming persistently absent. We see mental health in her adolescence. At age 16, she's not in employment, education, or training. Enters the criminal justice system at age sort of 20. And if we follow her life through, we find that she has multiple long-term conditions in midlife. And Tracy is just, as I say, an archetype, typical of just far too many children that we can observe within our database. And I think this just starts to illustrate how we can understand the accumulation of risks across these different domains and how they play out across sort of time. So say Tracy was born with 22q deletion sort of syndrome. And one of the powerful aspects of the connected data we have is our ability to start really understanding how these different issues sort of play out as a function of socioeconomic position and ethnicity. So we've called out all the CNVs across our born in Bradford population. And what we sort of find is that in our more affluent populations, there are no ethnic differences in the incidence of CNVs that are associated with neurodevelopmental disorders. About 54 CNVs that we know are associated with neurodevelopmental disorders. No difference in the prevalence when we look across ethnicity in our more advantaged areas. When we go into our more deprived, disadvantaged sort of areas, we start sort of seeing a much higher prevalence rate within the white British population than South Asian heritage population. So we start just to get a bit of an understanding as to perhaps where we should be looking and devoting our efforts. And I said before that Tracy was born prematurely. Of course, we know there are elevated risks to struggle within the education system if you're born prematurely. We also know there's a small but significant impact of the age you are within when you go to school for the first time. So the English education sort of system means that there's an 11-month difference in age between the youngest child and the oldest child entering a class. And we know that the younger children have an elevated, small but significant elevated risk of struggling within the classroom. But of course, what our connected data allow us to do is understand what happens for those children who, by virtue of being born a few weeks early, end up going to school a year earlier than they otherwise would have. And what the data clearly show is that these children really struggle within the education system. So these are information which just reside within our routine administrative data on all our sort of our servers that are indicating very early on that we've got individuals who are at elevated risk of struggling within our sort of our systems. And we're just not using that information effectively right now. And that seems a crying shame. And it's just an illustration of how connected data could really help us start acting more early to start intervening and addressing some of these issues. And I mentioned that Tracy has a congenital anomaly, and large numbers of children within our population have these congenital anomalies. And there's been increasing evidence sort of suggesting that congenital anomalies, even when they're relatively sort of mild, are a risk factor for children not doing sort of so well through their educational journey. So we were able to test this notion within our data sort of base and clearly showed that congenital anomalies of any form are a big risk factor for children then really doing poorly later on within their educational journey. The reasons that aren't fully sort of clear, but isn't related to the type of congenital anomaly and isn't related to the severity of the congenital anomaly. It just seems that some kind of disruption to the genome is putting these children at elevated risk of really struggling to achieve and thrive within education. And of course, it's only the connected data sets that allow you to start getting that read across from the problems that we're seeing within a clinical setting, and then really understanding how they sort of play out in another setting, in this case, within education. So you can see how these connected data sets are just allowing us to take that more holistic sort of a viewpoint and look a little bit sort of forward in time, sort of understand what are the consequences of these early sort of factors across the lifespan. And then the other advantage of these big connected data sets is they allow us to start modeling these different effects and start properly understanding what are the costs broadly construed that are associated with these early life sort of factors. So one of the things that we were able to do with connected data sets, this is actually a national data set, is start doing that sort of modeling and start having a look at what's the impact of a child growing up in poverty in the first year of life in terms of the long-term consequences. And the modeling showed quite clearly that growing up in an impoverished household within the first year of life greatly elevates the risk that at age 17, you're going to have multiple difficulties across multiple domains. Again, something that we just can't see. We're only looking at the data through an education perspective or through a health perspective or through a social care perspective. When we start having that holistic viewpoint, we can start proper modeling the impact of all these effects. And of course, that then is very important for winning arguments with Treasury about the importance of investing early on in children, young people's lives. These connected data really allow us to start doing effective modeling. And they start allowing us just to start really sort of teasing out the different pathways from those early factors through to ultimate outcomes. So the type of work that we've been doing with colleagues down in Wales through the Link Consortium is looking at the impact of adverse childhood experiences on individuals' long-term physical and mental health, and particularly looking at the influence of adverse childhood experiences on that really toxic mixture of diseases that affect the mind and the body. So that combination of internalizing disorders, so anxiety and depression, together with cardiometabolic disease, and showing unequivocally that those early adverse childhood experiences experienced by our archetype, Tracy, play out and, of course, create huge pressures downstream on the NHS. So we can just start understanding those different pathways. And we can start looking at how different organizational sort of pathways cross one another. So within our connected data sets, we're able to show a relationship between the school readiness measure, which happens when all the children in England turn up to sort of school, and the likelihood that that sort of a child will then go on and end up with an autism diagnosis. And we were able to establish a very strong association between a child's school readiness, not reaching a good level of development, and ultimately ending up with the diagnosis of autism. And we found exactly the same patterns when we looked at the probability that they'll end up on the special educational needs register. And in fact, we could actually model that all the way through to the probability that that child ends up not in employment, education, or training. So we can just start to really untangle these different pathways. And we're particularly interested in the impact of school absence. So within Bradford, pre-pandemic, we had 3,000 children persistently absent from school. Post-pandemic, we now have 30,000 children persistently absent from school. And this is a crisis for us across the district, but we're just a microcosm of the UK more generally. And we can now start to tease out the different factors that are driving that school absence sort of a crisis. And lo and behold, we find that special educational needs are a big risk factor for children not feeling they belong in school and ultimately starting to become absent. We also find that proxy measures of poverty, like free school meals, are a big driver of school absence. And worryingly, the relationship between school absence and ultimately ending up as not in employment or education training is there to be seen within the data. Now, we know that we've got a massive problem with NEET within the country. That's why we've got the Milburn Review. We've got close to 1 million young people who are not in employment, education, or sort of training. And what our data are clearly showing us is this is a problem which is not going to be going away anytime soon, given the large numbers of children who are persistently absent from school. And of course, once you become not in employment, education, or training, we can sort of follow that through. And lo and behold, we find that that's then a risk factor for individuals entering the criminal justice system, with all of the associated risks to long-term physical and mental health that we know are associated with that justice sort of system. And once you get into the justice system, it's really hard to get out. It's like a flywheel. So once individuals enter that system as either victim or perpetrators, we're really setting them on a trajectory where the long-term consequences are very, very deleterious. Um, and I hope that just sort of illustrates how these big connected data sets are allowing us just to track those sort of pathways and help us sort of understand observations like the observation that copy number variants are a risk factor for multiple long-term conditions in midlife. So we can restart understanding what are the potential mechanisms that sit behind these relationships, which we and many, many other people have revealed. The other thing I love about these big connected data sets is ironically, they're really good ways of engaging with our communities and tapping into individuals' lived experiences. So we've developed a tool that we call the Clever tool, which is connecting lived experiences with visualizations of electronic records, which allows us to take our data insights and then really engage with the community to help us understand what are the various factors that are playing out in people's lives that are sitting behind these patterns that we're seeing in our big connected sort of our data set. Bradford, we're really committed to that co-production of our research, to really understanding, working with communities to understand what on earth is sort of going on. That mean we've got 4.5 million children growing up in poverty within our country, that we've got a SEND crisis, that we have an autism assessment sort of crisis, that we have all of these various sort of problems sort of playing out. So as I say, we're really committed to trying to take those lived experiences, learn from those lived experiences, and use those lived experiences to make change. And if you ever get an opportunity to visit the Tate Modern and have a look at Stacey Emin's exhibition, I'd encourage you to do that. I think it's impossible to see that exhibition and not be very upset and very angry and start asking what can we do that will allow us to build a country that works for all children and young people. And I believe that part of the answer to that question is we've got to start making more effective use of our connected data sets. And I do think, what would happen if we just been better at supporting Tracy through our educational sort of system? To what extent could we have mitigated so many of the problems that then played out later on in her life? And I like just to point out that education is one of the most powerful tools that we have to protect individuals and give them the best possible physical and mental health. So there's some of the ways that I think connected data can really help us with the SEND sort of a crisis. I also believe that these connected data sets provide us with powerful tools that allow us to identify need much earlier and support a child's sort of needs at the earliest possible time. And this is something we're trialing in Bradford thanks to generous ESRC funding. We're trying to develop sort of tools that allow teachers to identify those needs and support them at the very earliest possible point in sort of our time. And you can learn much more about all of this sort of work if you look at our Children North reports. Really encourage you to do that. Over a 12-month period, we produce monthly reports tackling the issues that were identified by our system leaders as the 12 biggest issues that need to be addressed if we want to build a country that works for all children and young people. So please do look at our Children North reports. As I say, they contain a lot of the information that I'm providing here. And the final point that I want to make about the use of connected data is its ability to support evidence-based policy making. So we've got the NHS 10-year plan, which is all about prevention, all about using community settings, and all about moving from analog to digital. Well, analog to digital for me is making better use of our connected data sets in the way I've just been describing. Prevention for me means focusing on children and young people, and that's what the evidence says that we need to do. And community settings, when we're talking about children and young people, means making best use of our educational settings, nurseries, schools, and so on and so forth. The Schools White Paper has now sort of come out. I think that actually gives us a really nice roadmap for thinking about how we can build a country that works for all children and young people. And I do think that the connected sort of data sets really allow us to get the insights that we need, the evidence that we need to ensure that that legislation is based on the best possible science and very, very best possible evidence. And I believe we really, really need to take that evidence-based approach if we want policies that will ensure that every child and young person gets the very, very best possible start in life. So if I can just quickly recap 7 ways that I think connected data can really transform our understanding of how we can support children and young people, how we can address the SEND crisis. So I think it gives us that holistic view over time. I think it allows us to understand the accumulation of risk. I think it enables accurate modelling, very, very powerful when we're dealing with Treasury and trying to make arguments for earlier investments. I think it allows us to understand pathways to disease and adverse outcomes. I believe it helps us connect with individuals who have that lived experience, either as practitioners or in their own lives, or both. It provides powerful tools that allow us to intervene earlier, more effectively. And finally, 7th sort of point is I do believe that it supports evidence-based legislation. And that's where I'll end it and now hand over to our brilliant colleagues, Dougal and George, and then hopefully we can have some Q&A on all of this stuff later. So if I stop sharing now and hand over to Dougal and George.
Thank you so much, Mark. As always, it's really inspiring and a huge pleasure to hear you and others from the Born in Bradford group presenting that work. In a minute, George is going to present some work we've done around mental health crisis using a similar approach around linked data in Northwest London. Before we do that, I just wanted to kind of manage expectations. We don't have the same richness and we don't have the same breadth and history that the Born in Bradford team do. But the reason we thought this would make a good double act and we wanted to present together today is that I think we share 2 passions. One is that is the value of local linked data sets and how they can complement national data sets. So the Catalyst program that kind of Lucy presented at the beginning is quite rightly focused mainly on national data sets, and there's lots of policy questions that are best answered in national data sets. But I think we have found there are certain questions and there are certain gaps in those data sets. So within health, we think about primary care data is often more difficult to link in national data sets. So there's an important role and we need to think about how we can use those, triangulate and complement both those kind of data sets. The second common passion, I think, is that local data sets, as Mark's already talked about, they can often be really empowering in those conversations, presenting local data to local communities and getting feedback, discussing what those data mean, discussing how we can best use them, but also use them operationally for how we can commission services within the NHS, how we can improve join up between education, health and social care at a local level. So just a very quick bit of background before we start talking. So this work came out of an ADR UK grant that was back in 2022, and it was a joint bid between us at Imperial College and London councils. And it was initially focused very much on a joined up approach to health and social care, children's social care. So I'm sure the numbers have changed by now, but what we talked about then is there were 10,000 children and young people who were looked after in London.
Can I interrupt you, Dougal, just to say that you're not yet in presenter mode?
Oh, okay. Thank you.
Sorry, you are in presenter mode, but you're not in slide mode. It's the right way around.
Oh, right, okay. Thank you.
Thanks, Lucy. We'll try that again. So at that point, yeah, there was this, there were 10,000 looked after children across London, costing the system around 750 million. And there was a real push to say these were a little bit like the Tracy Emin story and the kind of the others that Mark's presented. These were often children and young people who'd fallen through the gaps or been let down, had numerous needs that hadn't been adequately met at earlier stages in their life. So the idea was how we could think about both further extending the links within the NHS and also link to social care and potentially to education data from local authorities as well. So the social care story I will come back to, that has been a slightly slower burn. A big focus over the last few years, which George is going to talk about, is how we can understand children and young people presenting in mental health crisis, how we can understand and perhaps prevent or intervene earlier in some of those people, and both improve outcomes and make the system work more effectively. So over to you, George.
Thank you very much, Dougal. A wonderful introduction. Can everybody hear and see me? And you can see the slides, but not presenter mode.
Yes, correct.
Excellent. So this is the short presentation I'm going to give, identifying risk factors associated with an increased likelihood of children and young people reaching mental health crisis in Northwest London. So a little bit about WISIC Whole Systems Integrated Care, or known by its de-identified researcher platform, Discover Now. So the reason to have initiated it was because there were 8 local Northwest London clinical commissioning groups, and they wanted more integrated care data and less siloing. So primary care, mental health care, secondary care, you name it. WSIC covers all of these. That's the major strength of it. A reason to use it, a reason for its generation is that when you want to evaluate new health services and see if they're being well used or not, you've got to say a targeted intervention. You need the whole target population. Getting a snapshot may not be the most insightful thing. And WSIC provides that. And CCGs really need to understand what's clinically effective and what's cost effective as well. What's the patient experience and what are the interactions of clinicians with this data? So it's approximately 98% of Northwest London. And in fact, I think this figure of 2.7 million is out of date. I think it's now covering 2.9 million patients. And when clinicians interact with it, I think in clinic, I can be corrected on this, there are disease-specific dashboards, but otherwise the data is de-identified. So this is routinely collected data and it's de-identified for researchers like me using it. Briefly on the data architecture, I'm by no means a data engineer, so I shall not be able to adumbrate in a really eloquent way on it. Nevertheless, you have several steps to the different, for example, Tableau sites that one can interact with. We have Apollo that extracts data from primary care systems. Then this company purges sensitive codes like abortion codes and patients who opt out of clinical record research. And then they pass the raw files to our colleagues in the WSIC team. The data is passed as well through an ETL, extract, transform, load layer of WSIC. And what's so handy about this is that it's got error handling features. So it will, as far as one could hope, it will clean the data. And then the primary care data is processed in a separate black box view, so to speak, which has restricted access. So all of these different features are trying to make it as safe as can be and protect patient data. So that, I hope, is WSIC covered in a sufficient way to understand more about why we use it. The background to this project specifically, we know that there is a cohort of children and young people who attend A&E in crisis and they're admitted to an emergency bed via psychiatric liaison services. But a lot of these patients have a very complex social situation. They may not have a permanent address and whatnot. And so there can be a lack of, there can just be an inability to safely go home. And so they remain in hospital beds. And this causes many problems for the local authorities and the NHS. And of course, this is awful for patients. And it has very significant costs for local authorities and health services. So for just one area, it can be £765,000 annually. And I think this figure was generated a couple of months ago, so it's probably risen in cost since then. So this project of looking at potential risk factors for mental health crisis, there are lots of different ones one can focus on. We have in WSIC a unique property reference number that allows us to get, within reason, the address of each patient. We can look at their deprivation, their area level deprivation, as shown by index of multiple deprivation. We can look at the different, one of the Northwest London boroughs they live in, one of 8. Of course, there are basic demographic information. But what is also great about WSIC is that you have this richness of primary and secondary care data. So you can look at GP consultations, A&E visits, outpatient appointments, inpatient admissions. I think CAMS contacts, Children's Mental Health Services, it's just come online, but when I conducted this work approximately half a year ago, I don't think it was available to me to readily use. However, some social care data is available. I think it is therefore maximum of 3 of the 8 Northwest London boroughs that we have that are in WSIC. So it's not 100%, unfortunately, and school data should be coming online in a month's time, or
to be decided.
Ongoing
negotiation.
Unfortunately, it's not all present, but this is a very idealized diagram of what we would have in terms of risk factors studied. But just to highlight that what I studied was sex, age, ethnicity, deprivation, North West London Borough, health service contacts, and for some boroughs, social care episodes, and I'll focus on results for the borough of Harrow. The two main objectives of this study, first of all, develop a working definition of children and young people's mental health crisis through ICD-10 discharge diagnosis codes, and then identify early risk factors that increase the likelihood of a mental health crisis using this WSIG data. So it was a case control study of 8 to 18-year-olds registered with the GP in North West London. The case group was 1,761 patients with at least one mental health related emergency department admission. And then the comparison group was all of the North West London children and young people without such a mental health ED admission. And as I said, the risk factors studied were a range of socio-demographic risk factors, as well as health service contacts for 4 different strands. This is the first result I'd like to show, just showing that grouping of different mental health related events by ICD-10 code. And R45 comes top of the different groupings, and then the second most common are F10, F19, and F50, F59. And we split up age into these 2 particular groups because there can be a bit of discrepancy. Just to have a disclaimer in this presentation, I'm not a clinician, I'm a scientist by training. But from my understanding, at 16 years old, there's a bit of discrepancy that a patient can be already admitted to an adult ward, or they could still be admitted to a pediatric ward. And you can imagine all the different problems that causes for health service planning. So this is why we have our age variable split up into these 2 particular groups. And you can see a bit of discrepancy in terms of the ICD-10 categories for the 2 groups, but nothing major. It's still R45 as the most common mental health event. I've been told by one of my supervisors never present a table in the presentation. Nevertheless, this, given this was a wee bit last minute, you'll excuse me for having it. This shows the different social demographic variables. And for each of them assessed, really interestingly, there was a statistically significant difference between the non-crisis group of patients and the mental health crisis group of patients. So we're seeing already there's palpable differences in their social demographic makeup. So for example, the mental health crisis group has more females as a proportion. The ethnicities of each group vary. So white patients and mixed race patients are overrepresented in the mental health crisis group compared to the non-crisis group. The age range as well, interestingly, of the mental health crisis group changes. So you see far more 16 to 18-year-olds. Deprivation is fairly similar. You don't see such big differences, but it generally does have a socially patterned gradient, sort of more deprived, more represented in the mental health crisis group. And there is certain variation between different boroughs. So Ealing, which is the biggest borough in North West London, sees a reduced proportion in the mental health crisis group. And Brent, Hillingdon see an increased proportion. So this is just one summary that a really key finding is that you're going to have more females in the crisis group. They're more likely to be of white ethnicity. Deprivation levels, they're not too different. There is some social patterning, but it was statistically significant nevertheless. So to go to another branch of the risk factor study, social care. As I said, we don't have social care data for all 8 North West London boroughs. Only 3, and I've focused on Harrow. Just to briefly explain how social care data works. First of all, you have child in need, which is just a patient's initial contact with social care services. So it's a top layer, least severe, if you will. Then another layer of severity is a child protection plan. when a child is put on such a plan. And then the most severe level of social care data is being placed into local authority care. So CLA, as it's been abbreviated to in our table. And what you see is that looking at these social care episodes before crisis, in the run-up to that mental health crisis for the Harrow patients, and a 2-year average for the control group, you see far higher rates of children being classified as children in need, higher rates of child protection plans, much higher rates of being placed into local authority care. So there's a real difference in the social care experiences of these patient groups. And just to emphasize that really stark difference, so approximately 15 times higher incidence of having at least one social care episode, and that is of the lowest severity, if you will. Just coming to the end of the findings of my presentation, health service contacts, so whether that be GP contacts, visits to A&E, outpatient appointments, or inpatient admissions, you see a very stark difference for patients undergoing mental health crisis and those who don't undergo mental health crisis. I mean, for all of the strands, it is markedly different. I'll just conclude with this slide. So we found that there were statistically significant differences in the risk factors assessed, and the 4 health services assessed as well showed much higher contacts for the mental health crisis compared to the North West London comparison cohort. We have some limitations, unfortunately. GP contacts can sometimes be spurious in a way. It could just be a text message to say that your prescription is ready. So there needs to be more legwork, more coding done to filter out some of the GP contacts that could be overinflating the numbers. School data we hopefully will get, so that could be some nice follow-up work to this study. And in general, one has to be careful with ICD-10 codes because they're very liable to human error. And recent work showed that, in particular, for mental health-related ICD-10 codes, if you go through it quite carefully by hand, you can actually pick up far more mental health admissions. So this is something where, if we had a little bit more time or we conducted a follow-up study, we could do it in a more detailed way. But nevertheless, we found some quite stark differences between our case group and our control group. And future work could involve digging down into those health service contacts and seeing, especially with CAMS data coming online, whether those mental health crisis, those children, young people undergoing mental health crisis were known to local CAMS teams. And quite a substantial piece of work in the future would be to even generate risk prediction models. So to be able to flag patients as being at risk of mental health crisis before they present to A&E, which could be a real game changer, if I can say so, for health service planning. So I'll end there. I'm really happy to open it up to questions.
Huge thanks, George. I will just do a couple of quick comments about operational impact at that point again, and then we'll open up to questions. And I wanted to go back to this slide. So I didn't introduce myself properly at the beginning, apologies. So I work part-time as a consultant general paediatrician at St Mary's Hospital, one of our acute local trusts, and the rest of my time in the School of Public Health at Imperial College. And with my clinical hat on, this group of children and young people admitted to our acute paediatric ward for primarily mental health reasons was causing us really big challenges in how we ran the ward and we delivered that clinical care. So big challenges both in how we delivered care for those individual young people. We're mainly set up to deliver physical health care. We're not primarily set up to deliver care for teenagers with often quite challenging behaviour, often quite complex needs. And there's also major knock-on effects. So paediatric wards are full of vulnerable babies, full of toddlers with a range of physical health needs. It was a real challenge for us how we can maintain the care for all the other patients alongside this group. So there was an understandable push from my colleagues and people working on the wards to say, we need more resources. We need to get bigger multidisciplinary teams. We need to have more resources to deal and support these children and young people within the hospital setting. And that was absolutely right. We do need to think that. But this graph was really crucial in helping us to frame that conversation in a public health and an early intervention approach as well. So it helped us go to our integrated care board and to wider commissioners and say, yes, we need to improve care for children and young people once they're in hospital, but we need to go upstream as well. These are not people who are coming out of the blue. They've largely been seen multiple times within primary care, within the A&E department, within outpatients. And so that led to a much more holistic approach. So we've improved training for healthcare practitioners across the way. And we've also developed alternative pathways where people identify a young person who seems to be on that trajectory or has mental health needs that are not being met. We now have different options to try and intervene before it reaches a crisis point. And similarly, as I said, we haven't talked about the social care work in detail, but we did some similar work, some of the stuff that George presented around the overlap between those in crisis related to mental health and those needing expensive residential care placements in the social care system. Some of these data helped inform a bid to DfE, which has resulted in a new children's home being built in West London for children and young people with those complex needs. So again, it's kind of showing some of that benefits of how we can learn from practitioner insights and use that to do better research, but we can also complete that loop and use the research hopefully to improve services and outcomes for children and young people locally. I will stop there. Thank you very much. And we should end slide.
Brilliant. Thank you to all our presenters. That was really engaging and thought-provoking presentations as well. The work that you're all doing is really timely and relevant given the mental health challenges and SEND challenges that we have across the UK. And I think it's really fascinating to see how linkage between different data sets can really help us understand these trajectories better. So I'm going to open the floor to questions. There are some in the chat. So I think Mark's answered some of them already, but I will read them again just in case there's anything he wants to add. So we've got one. Mark, so the different database sources, how are they linked? Is it a unique identifier, NHS number, CHI number?
So we don't, of course, have a single unique identifier in the UK yet, and that's obviously a hot sort of topic, a topic that Dougal is very involved with inside sort of a government in terms of that particular debate. But Dougal and I often observe that actually you can get about 98% of the way there using fuzzy matching sort of techniques, and that's what we do and have done within Bradford. And almost 98% of the discussion is around this single unique identifier, and about 2% as to actually what could we do just now with existing techniques. So I guess the moral of the story from our end is that actually we can, and I believe should, just crack on and get some of this sort of linkage done with immediate effect, whilst I would welcome further debates around a single unique identifier. Be interesting to get Dougal's perspective on that as well.
Yeah, no, I mean, I absolutely echo that. So yeah, to answer the question, we do the same thing as eChild does, as Mark does. I think it's largely fuzzy matching based on a range of different identifiers. For looked after children, there is an NHS number within their records, so sometimes that can be used to ease the matching as well. I think it's really important. We often talk at cross purposes, both at policy level and local level. So there's the important distinction between de-identified data and identifiable data, but also that I think that gets muddied with the difference between research and operational use cases. So the kind of stuff that we've presented today is where we've used those linked de-identified data for operational purposes, what we would call operational purposes in terms of commissioning services and designing pathways. But it's not that individual case management, the individual patient management stuff. And for that, that's where a single unique identifier, 98% or 95% or whatever we quote, is often good enough for the kind of population level work that we do. For individual case management, individual care, obviously that isn't always good enough. And so there's definite advantages in a single unique identifier there. And we know that the ones who don't match are disproportionately those with additional concerns. So disproportionately those in temporary accommodation or with frequent moves of house or other things, as well as those with kind of common names. And the other thing the other discussion about single unique identifier is the frequency of matching. So the stuff that George has presented tends to be updated. The linkage is done on an annual basis, which is pretty good for most of the de-identified purposes that we want. If we're using this for individual safeguarding discussions or anything, we obviously need either live or very near real-time linkage in order to make sure we're using the most up-to-date information.
Brilliant, thank you both. And then similar again, this is for Mark, for the Born in Bradford, around data sets and how it's created. Is the Born in Bradford unique for research, or can it be used for operational requirements within each local authority?
So I think Dougal's already addressed that. I mean, it depends how we define operational. We already use it for commissioning purposes. Or if I just give a concrete example, we as I alluded to, have a school absence crisis across Bradford. 30,000 children persistently absent. And the local authority's initial response to that was to have a Bradford plan to address school absence. But what we were able to show through the link to the data set is that actually about 20% of our wards are creating 80% of the problem. So it immediately allowed us to identify the geographical hotspots, which meant that the local authority could be much more efficient in their targeting of the issues. But also what allowed us to do is start teasing out what the drivers within these very disadvantaged sort of wards. And in one ward, we could see that poverty was a major driver. In another ward, it was far more related to sort of mental health. So as Dougal sort of says, that that's operational at some level. It's immediately sort of suggesting ways that our services can respond more effectively. Our big dream, though, is to actually get down to that individual sort of a case where we are able to share information, relevant information, safely and securely across, say, health and education. And we believe that this will be absolutely game-changing in terms of our provision for children with special educational needs within the Bradford District. So this is something that we're looking to trial over 2026.
Yeah, and George, someone's asked you how you've defined what a social care episode is, and how is this identified in the data?
Social care data, it's fed to us through a series of, I can't remember the plural, but it's a series of census data we get for each calendar year for social care. So it's not something that I have to from first principles generate. It's already there. It's simply a matter of data linkage to, say, our main patient table in WYSIP.
So just to add to that, for those working in social care, so what we get is the nationally mandated data set, so the SSDA 903, which is the Looked After Children Return, and the Children in Need Census. So we just chose to start with that because they're standardized and they're collected in a fairly consistent way. We absolutely recognise, and we've had these conversations with local children's services team, there's a lot of richness within those data, within the local data sets that don't make it into the national returns. And we'd be very interested in looking into some of those in the future, but it's not something we've been able to do yet.
And so someone else has also asked whether you'd be interested in looking at children and young people with education, health and care plans and support, particularly those as well in youth justice system. Is that something you can do at the moment, or something that you'd be interested in looking at in the future?
It's something we do and have sort of done, and hopefully some of the insights that we generated were useful to policymakers as they worked on the school's white paper. So yeah, these are exactly the type of things that you can do when you have these very, very rich connected data sets. Dougal's already said, obviously got some fantastic national resources, which are very, very sort of powerful. But I think both Dougal and I believe that these local connected sort of data sets can give yet further richness. We can really start disentangling all the multifaceted factors that ultimately determine a child or young person's outcome, which is why we're both passionate about trying to drive this conversation forward.
Thanks, Mark. Yeah, from our side, we're, as George said, we're working very hard on the education data, and we're really hoping we'll have linked educational data soon. The criminal justice and police data is a tricky one in London. So we absolutely recognise the importance of it. And if we talk about making an economic case, the huge costs young people get in that criminal justice system really can potentially help that kind of business case for investment. There is a bit more pushback from the public engagement side around linking police data. So we haven't talked very much about the next steps within London data sharing, which will be around the London secure data environment. So we'll be scaling up from currently around 2.9 about 9 million people in Northwest London to a pan-London data set, which is just under 11 million people. And the public engagement group has been very supportive of linking health, social care and education data. There has been more reservations from that group around linking police data. So that's something that's still being worked through at the moment.
Mark, did you want to?
Yeah, just to say that your Deputy Prime Minister has sort of launched the youth justice strategy, and within that there's a commitment to what they're calling preventative analytics, so looking at how we can use data insights to stop young people getting anywhere near the criminal justice system when they should be nowhere near it. So these are all very, very hot sort of questions, and hopefully sort of questions that we can help address. With regard I've spent a lot of time studying efforts to support local areas, connect sort of data sets. I do feel that one of the things that we managed to do within Bradford that was successful is use the NHS as the spine. So where areas like Bristol have stumbled before is trying to get NHS data pushed out of the NHS. And what we found through our extensive community engagement work and consultation is people do not like NHS data leaving NHS servers, but typically they're far more comfortable about data being pushed in to the NHS in order that care can be made more effective. And that's the approach that we took. So for me, one of the secrets of success is rather than trying to do it at a local authority area, do it, say, at an ICB area, and then have local authorities pushing their data through into the health space rather than vice versa. And certainly for for us, that was the game-changing aspect, where we could suddenly get everything linked in a way we couldn't manage when we tried other routes.
How do you see connected data being used alongside practitioner insights to identify early trajectories and improve outcomes before children reach crisis? They've gone on to add that they're particularly interested in how this might help understand pathways for neurodivergent children across the different systems.
So maybe I'll kick off and then Dougal and sort of George sort of come in. So I think there's sort of two separate questions. The pathway is sort of a question. I think it's a great one. And the point is that with the big connected data, you can start to disentangle the various sort of pathways that individuals follow. And that's revelatory when you do that, because of course each individual service has got a nice, A4 piece of paper with their particular pathway on it, which makes complete sense to them. But there's typically little consideration as to how that pathway links with all the other services sort of pathways. And when you do try and map the pathways out from the perspective of a family trying to navigate their way through these sort of services, it looks like spaghetti sort of at a junction. And I think that tells us a lot about what we need to know about the structural transformations that are required. So lots of interesting questions that we can and should be answering with immediate effect with regard to pathways. The question about how data can allow us to pick up need earlier is a question that lots of us are passionate about, and that obviously sort of sits behind the Deputy Prime Minister's desire to have preventative analytics. The reality is that lots of young people are just below threshold on a number of different services radar. And it's typically not until crisis happens they go above sort of threshold, and everybody sort of panics and tries to sort of work out what we can do to support that child or family at a point when it's very, very difficult. The advantage of connected data is you can start to pick up those red flags before they hit crisis. So obviously the implications of that with regard to stopping a young person going into care, with regard to identifying special educational needs early, with regards to spotting sort of children and trajectory towards NEET or the criminal sort of justice sort of system, that seems a huge sort of prize and offer, and that's within our grasp if we start taking the connected data work seriously. I'll hand over to Dougal.
Yeah, no, Mark, I'd agree with all that. Just a quick comment on that, what we mean by practitioner insight, because I think what we found is that, this is where the Catalyst has played such an important role. And I think I think Mark, in Bradford, these relationships have probably existed for longer. It's something we've invested a lot of time in over the last 5 years, is building up relationships between researchers and practitioners at different levels. we found you need at least 3 groups, really. You definitely need the clinical directors and the senior people and the who have that strategic vision and can understand how data can be used to inform service planning, inform budgets, all of those kind of things. But we equally need the frontline practitioners, the kind of the resident doctors who are working at A&E at midnight on a Saturday. We need the people who are the health visitors who are going out doing home visits, who really understand how that data would change their clinical practice, how they work with individual patients, individual families. And we also need that kind of cadre of practitioners who have a data interest. And we can always find those. It sometimes takes a while, but you can usually find those. And that's the kind of thing, when we come as researchers, I can give you a good idea of hospital inpatient data and how to understand it. Having worked in a hospital, I struggle with primary care data. We really need GPs and those who work in primary care to understand that. Similarly, we need people on the inside of the social care system, on the inside of the education system, to really help us interpret how these routinely collected data can be used best for research purposes. And without that, it's creating teams of people who've got those different insights, I think, is the challenge and where the real benefits come from.
And George and Dougal, Suzanne's asked, why did you choose to start at 8 years old? Why not 5 or 6 years old when looking at the mental health crises?
It's a great question. I mean, it's fairly pragmatic decisions. I think there were 2 aspects to it. One is that was the main clinical challenge. That was the operational challenge, was in those, particularly the teenagers, but some from 8 and 9 years upwards. So it's kind of pragmatic decision from that point of view. The second was, as George mentioned briefly, a lot of the coding was slightly indirect. We were using proxy codes and inferring whether something was mainly a mental health related condition. So it can be really difficult to see from the routinely collected data. So, for example, someone might come with very significant self-harm, but it might be just coded as a wrist laceration, and it can be quite difficult to see the difference between those two. Similarly, if we look at overdoses, they're often just coded as poisoning. So it's not uncommon to get 3, 4, 5-year-olds admitted with poisoning because they've put something in their mouth they shouldn't have. That's a really separate group from a 15-year-old who's taken a paracetamol overdose. So it was just a pragmatic decision based on those 2 things, I think.
Yeah. So I think we've got time for one more quick question. There's still a lot of questions in the chat, so I don't know if you have time to answer them maybe afterwards. But Claire's asked, do you have any advice on the legal framework that can be used to support administrative data linkage?
So precedent is always good. There's precedent there. So, the argument can be throw the lot in Bradford in jail before us. So do use precedent. But what I would sort of say is the legal pathways that we found really useful is to look at all of the statutory responsibilities that we have on our services, and then ask the legal question, if it's impossible for us to fulfill our statutory responsibilities without connecting data, can we connect data? And then you'll get the legal answer that this is a legally valid approach.
Yeah, I agree with that. And just to add to that briefly, so we used some of the ADR UK money to commission independent legal advice about the statutory basis for sharing and when it was appropriate and when it wasn't. So please do get in touch. Very happy to share any of that legal advice or some of our experience if that's useful.
Yeah, it's probably worth saying, like, Dougal and I work really closely, and we've got a little gang of like-minded people, and we're always happy to support other like-minded sort of people. The more of us that are sort of screaming for this to happen, the more likely it is we're going to get the change, and all of our lives will get a lot easier.
I'm going to close the discussion there. Very conscious you've got a huge amount of wisdom and you could just keep talking, but so we finish on time. I'd just like to thank again all 3 presenters, Grace for managing the Q&A, and you for all attending, really just picking up on really thoughtful questions and discussion. Marie's going to send you the evaluation link. Please do complete it as normal. Your feedback's really important to us, and our next event will be held on the 23rd of April. So thank you again, Mark, Dougal and George. Thank you, everyone.
Bye.
Thanks all. Bye-bye.
Thank you.